Facebook. Okay, guys, so let's start with the mock feedback. So question number 1. So a 23-year-old man comes to A&E, RTA, road traffic accident, and you see a metal went to his chest. Okay, chest, we don't know where. Okay, if it says here, heart, we all know it's going to be within the heart. We're not sure where. He's hypotensive, tachycardic, examination, JVP, distended, absent breath sound on the right side. Peter, what did you put for the answer?
I choose D.
You choose D, okay. What is your diagnosis?
Thinking of tension.
It's fine. So you say it's tension pneumothorax, okay. So this patient has tension pneumothorax. Why tension pneumothorax?
Because injury to the chest.
Yes.
So there's compression of.
But why not cardiac tamponade?
Could be.
So what in here does it say it's not cardiac tamponade? Anyone? Absent breath sounds. Yeah. So it's tension pneumothorax. Where is it? Is it the right side or left side? Tension pneumothorax. Right side. So it's going to put the needle on the right side. So answer is going to be C. Okay. Now new guideline. Okay. Tension pneumothorax. Okay. Obviously we know that there is no chest X-ray. It's based on clinical diagnosis, percussion, hyperresonance, absent breath sound. Two things. Okay. Differentiation for cardiac tamponade. When a patient comes, first thing you do, needle. Okay. Needle. Put a needle there. Okay. Aspiration needle. Okay. Just put a needle there. Where do you put it? That large Bow IV cannula. You put it in the affected side, right intercostal space. Intercostal space, right side or left side, depending on the side. On the affected side, if you have a pneumothorax here, put it here. If you have it here, put it here. Second thing, if the thickness is too much, you do it, patient got a thick skin, you can't put it in. Then you go for mid-axillary, fifth intercostal space. Okay? So our answer still stays the same. First line is C. Large bow cannula, mid-clavicular. If you can't do that because of increased thickness, then you go mid-axillary, fifth intercostal space. No, for the needle. For needle, yeah? So needle is still the same. What's the first thing? Is mid-clavicular. Second, if you can't do it because it's too thick, skin's very thick around here, then you don't try again until the patient dies. You move your site mid-axillary, fifth. Needle. After that, it's going to be chest ring. Okay? Number 2. In here, this patient here is brought to the hospital with chest pain. As you can see, ECG, what is this? So, ST elevation. So this patient we know has a STEMI. Okay? So what is the answer? Next person, sorry, for your name?
Summer.
Summer, yes.
I chose C.
You chose C. Why C?
But because there's no PCR available in the hospital and the nearest facility is 10 hours away, and the pain started 3 hours ago, so that's more than 12 hours.
Very good, yeah. So in here, patient has STEMI. Our gold standard is going to be PCI, but it has to meet the criteria, which is 12 hours from the onset of pain. Okay, it's already been more than 12 hours, so we can't give it. So next bet is going to be thrombolize them, alteplase or streptokinase, either of them. Streptokinase you should not repeat if they had it before because of antibodies being formed. Remember, STEMI is also be new LBB, will also fall under STEMI. Number 3, this is a patient who's got type 1 diabetic. He's got microalbuminuria. His BP is, what's his BP? 132/88. Rish, what's the answer? Start ACE. Why? So you're saying this patient has microalbuminuria. What is your target BP for this? What should it be? Why? What's the criteria? 130/80. Yes. So if the patient has 130/80 or above, we start the medication. So in here we know type 1 diabetes. We need to know type 1 diabetes is 135/85. If it's this or above, we start them on medication. If they have micro albuminuria in the urine is lower, 130/80. If they have this much or above, start medication. Type 2, bit different. If they have 140/80 or above, we start the medication. If the kidney is damaged, okay, if the kidney is damaged, if the eye is damaged, okay, if they have cardiovascular diseases, then our target is going to be 130/80, same as microalbuminuria. These targets, you need to know them. First thing, obviously, which will be helpful, will be ACE inhibitor. Number 4, this patient, obviously, what has he got? He's got ascites, some liver cirrhosis. What is the answer? Next, so Alenza, yes. Low dose furosemide. Why? So fluid overload, very good. Heart failure, we give them diuretic furosemide, but it's not heart failure. From liver cirrhosis, what do we give them? Yes. So in here, very important, guys. Heart failure, diuretics. That's fine. Diuretics. This is an ascites from liver cirrhosis. We give them spironolactone. What is that? This is a potassium-sparing diuretic. This patient will have hypokalemia because of the condition. So this is why this is the condition where we don't give them furosemide, because furosemide will cause what? Hypokalemia, hyponatremia. Okay. This patient problem is they have hypokalemia because of the underlying cause. So that's why we give them potassium-sparing diuretic, spironolactone. Second thing you need to know, spironolactone side effect, gynecomastia. Very important, yeah? Gynecomastia, okay? Next one, number 5. Okay, this patient shows ECG. What happened to him? He went in a life. So this patient, very important, Cameron, okay, is a 35-year-old man who has been on a fight and knife into his chest. In his chest, whereabouts? We don't know. Anywhere in the chest. He's hypotensive tachycardia. JVP descending ECG shows there. Next person, Samira, yeah?
Yes,
Samina. You put B. Okay, what's the diagnosis?
Pericardial effusion.
Pericardial effusion. Okay. Let's just say, okay, fine. Let's have a better word. Cardiac tamponade, you're thinking, yeah? Cardiac tamponade. Okay, why?
Because of the history where he had a knife wound in his chest.
Yes.
CP was down, the pulse was rapid, JVP was descending.
But you have the same thing for tension pneumothorax. Exactly same thing. How do you know the difference?
You said that there would be hyperresident.
But it's not there. So I can't say it's not there or not. That has not been ruled out. It's not there.
Could do that.
So it could be. So what is giving us this is, look at the ECG. Let's see who knows it. Look at the ECG, guys. So we have a low voltage. Fine, but okay, but some of them are okay. Right?
Sort of D wave the saddle.
No, that's going to be pericarditis. So muffled heart sound is not there, so we don't know, yeah? In here, tamponade, electrical ultrons. As you can see, if you look closely here, QRS, and then go small, right? Big, small, big, small, big, 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 small. Okay? Big, small, electrical ultrons. This is for cardiac tamponade. Okay? So muffled heart sound, electrical ultrons. Okay? Okay, number 6.
Number 6. Who's number 6?
Romana.
Romana? What did you get for number 6?
I put C here.
Good. Is that the correct answer? Can you tell me why?
It's because the patient reports visual disturbance at headache and the blood pressure is very high here.
Okay. So what's the guideline? We have to learn the guideline, isn't it? So it's a good answer because you would rule other answers out. So if you rule other answers out, then the question is C. But why is it C? Now, what does this patient have? Severe headache. Severe headache with visual disturbance. And examination, there's a retinal hemorrhage.
Yeah.
So there's 3 findings we found, and there's blood pressure of 185/122. So what's the guideline? Guideline is under. Where did the patient go to? GP, right? Patient didn't go to hospital. Patient went to GP with blood pressure of 182/85/122. Now the normal guideline I'll tell you 140 to 180, mild hypertension. 140 to 180 mild hypertension. 180 plus. Okay, so let's say take one. For example, I'll take everything out. I know 180/110. Remember that 180/110. Above that is called severe hypertension. Below that, mild hypertension, and then hypertension. Why the bottom ones that you don't have to treat it? So 180 or above 110 is severe hypertension. Now, if you look at the guideline, if you have any clinical symptom, in here, is headache a clinical symptom? No. Headache with altering GCS is a symptom. Isolated headache, we fix it on its own. Okay, so if you have a severe hypertension, blood pressure above 180, and you have headache, headache is okay, but headache with altering GCS is a problem. So if you look at the lifestyle and it says end organ damage. End organ damage is you check your kidney. If your kidney, check your kidney function, if it's gone elevated, that's it. End organ damage, you can quickly do it acute. Or you can look at that retinal hemorrhage. Retinal hemorrhage is the main case. Headache comes with visual disturbance. That's a problem. Visual disturbance with headache. So that is a proper headache. That's a neurological symptom. If I just say headache, when I was in A&E, I just get headache with high blood pressure, we monitor them, do an X-ray, we do an ECG, urine, and just monitor. Yeah, unless it's less than 180. This one has 180 plus, severe hypertension with clinical symptoms, 2 of them. Retinal hemorrhage with headache and disease. Okay, so with those cases, they need to go to hospital, they need to go to A&E, they might have to go to visa, depending on the end organ damage, we need to stop that. Okay.
Is it okay if you can put the BP down for that? So it might be easy, hard for Harvard. It's
So
Dr. Rai, the patient is comes only with the like high blood pressure, the GP,
Yeah.
without any symptoms.
Very
Then
good.
give the medicine, or you have to refer to the.
No. So patient comes in with just high blood pressure. Normally, if they come to hospital, we send them back to GP. So if you're going to GP will manage it with hypertensive blood pressure.
There is only they have the 180 or 110 blood pressure at the and no any other signs. So
If it's asymptomatic.
asymptomatic, then GP can treat like increase the dose or something like that. Or
Very good question. I said severe hypertension. Once it crosses 180, 110, that goes severe hypertension. They need to go to hospital to check everything.
oh, okay.
If it's below that and they have just high blood pressure, no symptoms, the GP will treat it.
yeah.
Easy?
Yeah, that's fine.
There's too much right. The actual actual guideline is very confusing. I said it as easy as
Next question. Number 7. This old lady coming of incontinence, urinary incontinence, sensation of pressure. She is referred and seen by the gynecologist. An examination shows bladder prolapsing into the vagina. What is the very okay? Amreen, what is the management for cystocele? Anterior polography. Yeah, okay. What is the management for rectocele? Posterior. Yes. Next question is number 8. 78-year-old woman. She's got heart failure, hypertension. She's got basically a cystocele affecting her life. She done all the sort of exercise and it's not, helping. She was referred for a anterior colporrhaphy surgery and she was not fit for it. What do we do, Shazia? Why?
Yeah, because she's not fit for
Yes. Yes. So you need to So you need to know, first of all, conservative management, exercise and all of these, so lose weight depending on it. And then best one definitely is going to be surgery. If unfit, bring pessary. Number 9, back to Peter. This patient is 56-year-old man, comes to review. He is hypertensive, non-hypertensive. He traveled to Wuhan, okay, for a holiday to see his family. Okay, but he did not get coronavirus. Okay, his BP is 200 or 132. He takes ramipril hypertension. What do we do?
Yeah, based on what Dr. Lai just said, I think there's no further information apart from the elevated hypertension. So I'm lost between urgent and review the next day.
Wait. Dr. Elahi said this. Above this or above, regardless.
Okay, then with that is C.
C, yes. Okay. Number 10. This man here is type 1 and basically, what's happening? His BP is 138 over 90. What do we do? Start ACE, yeah? So with regards to high creatinine, if it's high, just withhold it, okay? Just don't give it. Now, number 11, this chap has got liver cirrhosis, taking spironolactone, and he's complaining of breast has been enlarging. What does it cause? Yes, we mentioned already, spironolactone, okay? Don't forget this one, side effect, okay? This is a potassium sparing diuretic, okay? Number 12, 30-year-old man. He has been studying on Ramiprid, which is an ACE inhibitor by his GP, and the blood test showed that this guy's sodium is fine, potassium is fine, urea has gone high, creatinine has gone high. So what is the most likely cause? Yes, Alensa, yes. AKI due to renal stone. Okay, why AKI? Okay, fine, he's got AKI, but we're saying what is the most likely cause of the AKI? So you're saying renal stone, do you have any pain anywhere to say renal stone? So you just, okay, well, so what else could it be? Now, why? So you see, patients who's young patients like us, we should not get hypertension, guys. If we have hypertension, then it's not essential hypertension. It's secondary. Something like this, pheochromocytoma, renal artery stenosis. Patient who's 58, hypertension, arterial hypertension, yeah? He's elderly, yeah? But us, we shouldn't have hypertension. If you have it, we think, oh my gosh, has he got a pathology causing it? Like this. So look at the age, 30. Age, okay? Number 2 is contraindication. Renal artery stenosis contraindication can be ACE inhibitor. On auscultation, you may hear some bruise. Okay? So, yeah. So 2 things, yeah? Age, number 2, bruise, number 3, after starting ACE, kidney function gets really bad. Okay? So therefore, renal artery stenosis, very important.
But doctor, I got the hypertension, but I don't have any secondary reason.
Sorry, you wrote?
I'm also hypertensive.
Yeah.
I don't have any secondary reason.
That's very good. Then it's essential.
That's the most common. Primary hypertension.
Yeah? No, hypertension is, most of it is essential. Young patient, you need to think of secondary.
Yeah, they check all.
Yes, very good, I checked, alhamdulillah. Okay, very good. Okay, number 9 is 30, guys, 13. Okay, so this is a man here coming to the hospital with sudden chest pain, and it could be anything, PE, MI, or I don't know what's happening. GTN given, ACS, so GTN given, aspirin 300, so this is the ACS protocol. ECG shows what? ST elevation, so this is going to be what? D, it's saying best management. If it says best, is PCI. If it says most appropriate, PCI. If it says best, most appropriate, in here will be the same thing. There is no definitive because it depends. No, you can't really.
You said the next step, that would be morphine, right?
No, next step, no. Next step, no. Next what? Next appropriate, next initial, it depends.
Next initial.
Next appropriate.
It'll be next appropriate. No, if they use the word, in here it is basically in STEMI, if they say most appropriate, if they say the best test, PCI. That's the gold standard for STEMI. But if they say first initial stage, obviously you can give them GTN, aspirin, and so on. With this one, for ACS, you give them IV morphine. That will cause you to have this sickness. For them, you give them IV metoclopramide. Yes, we had a question.
That's the question in PABS that I was doing yesterday.
Yes.
And it was something similar. And
Yep.
it said the next step, and it was morphine.
Yeah,
Okay. Yes. So it depends. You see. So it depends. So PLAB is very, very, very slight question. It depends how they ask. Okay. So if they say sometime, if you read it, they say next step. Okay, it just means what would you do next, literally in real life. If they say in here best test, it doesn't care about initial anything. What is the gold standard? Yeah.
This is PCI, but
Yeah.
if it just said next, in another question, if it just said
Yeah.
next step, that would be morphine, right?
Well, it depends. It depends. I mean, is the patient? It depends on the patient. Morphine has no benefits of its thingy. It just has the pain.
Yeah.
Even GTN has not shown to improve mortality. It also has the pain as well because it causes vasodilation.
Right.
Okay.
For the next, like, if suppose they've given GTN and aspirin, and then they say the patient is still in pain,
Morphine.
so then the next step would be morphine.
Yeah. Yeah. Most appropriate PCI. Yeah, still. Yeah, because this is the gold standard PCI. Okay. Okay. Now, with oxygen, not every patient depends. If it's less than 94, oxygen. If it's COPD, 88 to 92. Okay. Number 14. Number 14. Okay, guys. So who's next? Romana. Okay. Okay. So what is this? Remember the trick. You do this and do this. Very good. LBB. Yes. So LBB. So what do you do? Excellent. PCI. Yes. Ambreen. Next, number 15. This man comes palpitation. He's hypotensive and he's got fast AVD 260. That's very bad. What do you do? Very good. Why?
Because he's hypertensive, so unstable.
Unstable. Very good. DC shock. Very good. If the patient was stable, first thing what do you do? Anyone? First thing. SVT stable.
Also, carotid massage.
Yes. Okay. Very good. Then adenosine. Okay. 6. Then 12. 12. Adenosine. Caution should be asthma and. Yes, very good. Wolff-Parkinson White syndrome. Number 16. Okay, Shazia. What's the answer for this? So this chap here, what's he got? He's got SVT, right? Yeah, and he's pretty much stable. So they tried to do the carotid massage, but it did not work. Now, what's the next step is going to be? IV adenosine, right? Yeah. So what two things should they be very cautious about or find out their own patient doesn't have? Yes, answer is B. Asthma and Wolff-Parkinson White syndrome. Okay. Picture number 7. So what does the ECG show? 17. Yeah. So yeah, if you can't tell, yeah, I'll tell you what to do. Yeah, look, very simple in the exam. Yeah, you think, oh damn, could it be AF or atrial flutter? Look at the rhythm. If it's irregular, AF. Regular, put flutter. If you can't tell, is it sawtooth? Is it fibrillation? Is it irregular or not? Irregular, AF. Not regular, put flutter. Okay, but you would see sawtooth or flutter. Okay. Atrial flutter. Yeah. Atrial flutter management, same as AF. Okay. Number 18. Summer, a 60-year-old, this is an old lady, comes to the hospital with palpitation for 3 days ago. Patient is unstable and the consultant wants to do a DC shock.
So, I mean, yeah, I was very confused. I chose B because I remember you said because of the formation of a clot, we need to rule that out. So we need to do a transfusion. Yeah. But at the same time, I was just thinking if the patient is unstable, would we have enough time to do it?
Yes, so if the patient is unstable, you will not have time to do it. So therefore, it will be give a shock. At the same time, giving them
Answer is A.
answer is A.
Okay.
Yeah. Because of because the patient unstable. Yeah.
Then we don't do it.
Yeah. So if the so you don't do it. If it's more than 48 hours, you need to do TOE to see there's no sort of, and then you can do it, right? If it's sort of, if you require more urgently, then you give the patient anticoagulation, long-term heparin, a heparin infusion. Okay, make sure they're anticoagulated, and then shock same time. Is someone hear me?
This one.
Yeah, that's true.
Okay. Oh my. Okay, next one is going to be number 19. Is that Rish next? Yes. Mom. Okay. Make sure you can see it, yeah? So, number 19 was, what's the answer, Rish?
I thought it was flicknite, but it's not there.
No, yeah. Remember, this patient needs to be anticoagulated as well.
Yeah.
Warfarin, yeah. No, B, you see, long term is going to be warfarin. Okay? Short term, good question. Most appropriate. Yeah, so it's an answer to be A. Yeah, you start first with B plus warfarin for a few days, and then you sort of change into warfarin only. Answer is A. Number 20. So this is James, a 67-year-old man, heart failure. He's got, who's next is Alensa, right? Yeah.
Right control.
So what is the ECG showing you? AF, why AF?
There's absent P waves
And?
irregular.
Yep. Good. So it's AF. Very good. So what will you do?
The rate control is what beta blocker.
Now the patient has a heart failure. So I'm going to answer it C. Digoxin. Yeah. Okay. Okay. Number 21. A 58-year-old. Who's next? Is going to be Samina. So what's the answer?
I wasn't sure about this one. I put down C.
C. Yes. So that is a nodule. Yeah. So rheumatoid arthritis. Yeah. Answer is C. Rheumatoid arthritis. Yeah. Okay. Number 22. I'll leave it to Dr. Mehdi. 22. Yeah. No. Davis.
Yeah, next one. Who's next? Romana? This is easy. If you get this wrong, yeah, they
For 21,
yeah,
like seronegative and seropositive.
zero positive.
Yeah, how would we do?
That was the thing I was confused too, because why seropositive?
Do you know what? Yeah, seropositive, serology positive for rheumatoid arthritis. That's what it means. It's a technical words. It literally means seropositive, serum positive for rheumatoid arthritis, serum negative for rheumatoid arthritis. Funny, innit? It's just if I break down every single word, doctor's easy. Okay. All right. Next one. Oh yeah, rheumatoid arthritis. Yeah. Yeah, I'm doing like crap questions. So what's next? 23. Who's 23? 22 has no explanation. It says rheumatoid arthritis. What's the diagnosis? If rheumatoid factor.
And someone asked me, they're confused, is a Smith antibody? It's so clear, I don't know where they got this from. Rheumatoid factor. Yes, Smith antibody is positive in some of the patient, but it's not diagnostic. Rheumatoid factor here.
23, I'm a little bit confused with the negative.
Oh, 23 is not mine. Oh, okay, 23. Okay.
C,
What's the question? I didn't even read it. Okay, so painful left knee. Here was swelling on the pain. Yeah. So it says Chris 2. I can say Chris 2 straight away. I didn't even read the question, honestly. I didn't even do these questions. Chris 2 is negative birefringent. That's it.
And it's not septic, normal limits, normal vital signs.
Okay.
the pathology.
Forget pathology.
Gout.
No.
No, the answer is furosemide.
No. I'm telling you, is when it says Chris 2's negative birefringent Chris 2, what does that mean? Gout. Remember, I said that's the first thing I said. Well, I'm going to say again. I told you gout will come up. Gout is negative birefringent. And fake one, which is pseudo, is positive. Okay? And I didn't even read the question. Do you see? I just read that line because I didn't even... So given the likelihood of the recent... Okay, now... which medication may be specific? Okay, so it's furosemide. Do you remember I told you furosemide? Yeah, that's it. So it doesn't make sense. So one piece of information, you know the answer very straight away. Anyway, 24. Very good. How? How do you know that? Very good. So is it?
Yeah, there's feel difficulty even combing on your hair and purple rash on her upper eyelid with some edema.
Okay. Do you remember the picture I drew? Is this one, isn't it? And I gave you a face. Yeah? So you have cheeks, malar rash, and you have eyelid brushes, yeah? And Imran made this question so as well. So all you have to know is muscle weakness is going to be present in rheumatology questions. Look at the CK, if it's up or not. If it's up, it's going to narrow it down for you. If skin involved, it's going to narrow it down to you. This one, CK is up, and your skin is involved, and his answer is A. See? Sometimes it's easy from the lectures, but if someone tells you, it makes it easy, isn't it? Yeah, that's called spoon feeding. So 54-year-old. Yeah, so 25. Who's doing 25? Peter?
I think this narrows the PMR, so the most diagnostic would be muscle biopsy.
Very good. Remember, I said diagnostic biopsy. Go for it. That's it. A PMR, diagnostic biopsy. Very good. 26. Which one?
26.
Yep.
Rheumatoid arthritis.
Rheumatoid arthritis. Why? Where is the on examination? We just have to read that. On examination, there is erythema, swelling, tenderness of MCP joint,
And it's worse in the mornings and
and worse in the morning. So it's giving you 3 things: worse in the morning and MCP joint. Okay, let's go over MCP joint and what other joint for rheumatoid. Look, it's easy, yeah? MCP joint and this joint for rheumatoid arthritis. The last one for osteoarthritis. The first 2 is for rheumatoid arthritis, guys. These 2, and the top one is the osteoarthritis. So if you see someone elderly lady or anything, you see the just next to the nail is the nodules here.
And sometimes the osteoarthritis mostly they say that they involve the large joints and the muscle.
Yeah, of course, large joint. Yes, definitely osteoarthritis. That's why they have a knee pain, hip pain, hip pain, knee pain is that's why they do hip replacement. Yep, good. Well, who's next?
What is 26?
26 is B, yeah, rheumatoid arthritis. There's a picture, PIP and all of that. 27?
In first line treatment and then
Very good. See, clear now. Is there inflammation? So you're going to treat it with anti-inflammatory. There's no explanation. 27?
28.
Or 28, yeah. Yes, I can see eyes are sore. Can you see? Can't see, can't pee, can't climb the tree. All right. So all of these things, infection. Then you have your. Remember, that's not infection of the joint. All right. Infection causing inflammation of the joint. If I say infection of the joint, that's a septic arthritis. Don't get confused. So that's a reactive arthritis, a reaction to an arthritis. Yeah. Next is yours.
Okay, who's next?
Oh, it's me, 'cause
Yep.
I didn't know the answer to this.
So, what's the question?
I didn't know what it was. A mother brings her 5-year-old boy to see the GP. You notice that they requested a translator as they visited from Japan. I know that shouldn't be there.
So, patients from Japan, very important. 5-year-old Japan.
The mother explains via the translator that the child has been unwell with fever for nearly a week. On examination, his eyes are red, dry cracked lips, and a rash on his hands and feet. He also has cervical lymphadenopathy. What's the most important investigation to rule out complication of this condition? I thought it was C.
So, this is Kawasaki. So, echo.
Is it echo?
So, diagnosis is Kawasaki. Yeah? Japan, 5-year-old. Okay.
32? 32? Huh? 30. Oh, okay. 30. Pseudogout is correct. Why?
It should be on masturbating.
Positive rhomboid shaped crystal, positive bifringent. Remember, it's opposite. Fake one is positive, pseudo is positive. Yep, you just go straight to pseudoarthritis.
For gout. What's the treatment for gout?
They should know it.
NSAID. And then? Yes? Yes, next. Wait, no. NSAID, because there was that line. Prednisolone. Allopurinol, when do you give it? When should you not give it?
Initially.
Allopurinol is a
Prophylactic, guys. I've been telling you guys.
When a patient has an acute attack, don't start.
Julian is on the phone.
Oh, okay. Hello? Hello, Julian. Hi. I'm good. Hi. Oh, okay. Oh, okay. Okay, let me when you finish. Hashim, I spoke to Hashim when I did use it. I said, how long can I stay until? He said, it's fine, 7, 8, fine. Yeah, oh, okay. Well, obviously, this is why I was trying to get a communication with you guys, so it makes it easier. But obviously, I've been trying to. But Hashim, I spoke to Hashim when to come, when not to come, when to leave, and I spoke to him, and then we didn't say about 5. He can say I can stay until 7, 8. It's fine. That's fine. Obviously, if I say to you I'll finish at 5, then we would have finished at 5. If I said to you I will finish at 5, then obviously I would make it routine. That's why I spoke to Hashim earlier on that I'll finish. But obviously, you know, your stuff is to go. We can finish in, let's see, in 20 minutes, half an hour max. Yeah. So just to let you know, so tomorrow and Monday will be, yep. Tomorrow I'm starting 9 o'clock, but you will finish around 7, 8, like around this time. Yeah. All right then. Thank you. Bye. Go on. Thank you.
Welcome. Deci de las lor cheia? So can you just wait 1 second?
Yeah, yeah.
You're coming early in the morning, yeah?
Yeah.
Do you know from where to collect the key?
The
Okay, okay.
the
So I'm
toilet
gonna-
at the top. Yeah.
This is the key. Let it double check together, yeah? 'Cause
Okay.
we're gonna leave like in
Okay.
5 minutes.
Do you want me to close it?
Yes, please. After
Yeah.
you finish, because I'm gonna be here.
Okay.
And put it over there tomorrow morning. We're gonna collect it, yeah?
Okay. So I'm going to just close this door. That's it.
Yeah, but let's double check if it's working. Come on. No, this one.
Yeah.
Maybe it's quite. No?
Yeah.
Is this one, yeah? So you were gonna close.
Yeah. I'm going to close.
And you were gonna open.
And yeah.
Okay,
I'll close
I'm
and
gonna
I'll-
leave it with you.
Okay. Thank you. I'll close, and when I open it, where do I leave the keys? With me, or put it back?
Yeah.
Same place. Yeah.
Yeah.
And it says here, it's getting worse, worse at night, better with activity, okay, morning stiffness, okay. As you can see here, he records no trauma to his back. So it is ankylosing spondylitis. Remember, this patient, they need to do exercise. They need to be moving. Okay, take some paracetamol, take some, take NSAIDs and move. Okay, not helping, physio. So answer is not physio straight away. Stay active. After that is physio. Okay, so NSAID and physio, they go together. They go together. Okay, as you can see, bamboo spine. Bamboo spine, yeah. HLA-B 27. Okay, this is autoimmune. Mainly autoimmune is linked with female. This is the only one mainly linked with male. Remember, ankylosing spondylitis has an eye feature. What is it? Iritis. Very good. Don't forget the iritis. They commonly asked the exam.
Wait, is it 34? Who's doing 34?
I wasn't 100%. I was confused between NSAID and then corticosteroid injections.
Where's the corticosteroid injection? Okay. What's the question? I haven't even. So she has noticed some bony tenderness,
Osteoarthritis.
osteoarthritis.
Yeah. So she's already tried paracetamol. It didn't help. So then
So what is your
Okay.
pain ladder?
Pain ladder.
pain ladder.
Yeah.
Is that what you want to follow?
NSAID. NSAID. Now problem. 68. NSAID. It does. We've every in our notes he said don't give NSAID to these people. So it should have been NSAID with PPI. Okay. Elderly patient like that you don't want to give NSAID. You're gonna have bleeding.
Corticosteroid injection.
No.
You can,
but
but not in
It
that
is one of
stage.
the treatments.
Yeah.
He's saying what's the most suitable in this case.
Yeah.
Yeah. So she only tried paracetamol, right?
Yeah, she already tried that.
So
You want-
next step, NSAID. Why would you give her injection only in the? I think that will cause more problem for her.
I was confused. That's why.
And these questions are more realistic as well. Think of it realistically. You're not going to give an injection to every arthritic patient.
Yeah. So with osteoarthritis here, paracetamol, NSAID, not getting better. Injection in
Localized.
in the area
Joints.
in the joints, yeah. And then if it's affecting the life significantly, last is joint replacement. That's the definitive.
That's the quality of life if it decreases. That's why then we go for
So
it.
you have to go by, but you have to do all the other steps. You can't go to last step straight away. Okay.
This is penicillin.
Yeah. So this is what's the diagnosis? Yeah.
I mean, TCA. 35 or 41?
35, yeah.
Yeah.
So 36? Okay, 36, no mind.
What is 35?
Yeah, 35 is
C.
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 It's prednisolone. Polymyalgia rheumatoid, you give them steroids. Okay, high ESR. Now 36. Who's next? Yes. She has bradycardia. So 70. This is saying a 75. So old man, osteoarthritis.